Is it good? Not working? One. Good morning, everyone. Where is Ulrich? Thanks for the presentation. It was very great. We learned a lot about breastfeeding now. Now, honestly, when I was coming here, it was raining a lot. So I wasn't sure, should I come with the swimming suit or this suit? So I think I picked the right one. In Melbourne, we used to say, if you don't like the weather, wait 5 minutes. I think here it works 24 hours. So if you don't like it, change. Anyhow, now speaking about women that Ulrich did and under diagnosis, women with acute coronary syndromes are 50% more likely to be misdiagnosed than men. And somehow we know patients with skin of color are less likely to receive pain medication than white patients for the same injuries. It's very good. Why? Okay, so hold that thought. Now, as clinicians, nurses, paramedics, we like to think we are rational, objective, and evidence-based. And we pride our decisions based on science, not prejudice. But what if I told you, despite all of our training, experiences, and best intentions, every single one of us, including me, makes biased decisions every day? Not only at work, but in our daily life as well. Not because we want to, because our brains are wired that way. And the worst part is, we don't even realize it. Interesting, huh? Now, before we go through that topics and discuss it a bit further, you might have seen or heard, or now you see it, about this book, so which I had the opportunity to be a co-author and co-editor of that one. Now, I'm a clinician, as I mentioned, not a businessman. Therefore, whatever numbers you're seeing there, it's not going to me at all. So Springer did a good job to marketing and publishing it, and that was enough for me to get the words out so people know what's going on, and hopefully whatever we mentioned can be prevented. And hopefully sometime one of you guys might help somebody and make life better for them. Now, but we didn't have this agreement with Springer that I cannot give one of these books as a gift. Okay, so there's a loophole. Now, I want to make this session a bit of sort of interactive one. And if you make sure you're connected to your internet and you have your phone ready and trying to be interactive, you might get a soft version of this book as a souvenir, plus a complimentary coffee from Quentin and Dylan after this session. Okay. So everybody was excited about the coffee, but not the book. Interesting. Okay. Now, anyhow, now we can't escape bias. So in emergency medicine, we deal with uncertainty every day. We deal with probabilities, and we know that if we are really, really, really lucky, only 20 to 30% of our patients go out of our departments with a diagnosis. One of the registrars recently came to me and said, I saw this patient and I have no freaking idea what's wrong with them. And I said, I'm not sure if I can help you, but let's work out and see what's not wrong with them rather than what's wrong with them. So that's the word we are dealing with. We are facing risks every single second that we are working. Now, our unconscious mind is very amazing comparing to our conscious mind. Now, it works automatically based on the background, based on the cultural environment and the personal experiences. It comes to a conclusion and using a shortcut. And unfortunately, most of these conclusions are wrong. Again, how do we bypass it? So about 11 million points of data and information gets thrown at you on a second. And sadly, our brains are only able to process 40 of them. So you see what we are dealing with. So that's the comparison exactly between the thinking brain and the feeling brain. So that's when we are talking about preconscious bias, unconscious bias, which are personality and neurobiologically driven. That makes the bias a very, very, very complex process. Now, if you are thinking, you don't know which kind of thinking you're using. Are you using a type 1, which is unconscious, and you're coming to the conclusion quickly? Or you need to use some energy and come with the type 2 thinking, which is more rational and hopefully less biased. Now, let's do a bit of practice as like daily exercise. Now, let's call this group on the right side group A, and this group on group B for the purpose of the interactivity and hopefully the book and the coffee. The coffee and the book, sorry. Now, if you see these graphs, and if I ask you, which one is progressing? Group A. Green. Group B.
Red.
Red. Awesome. Now, why we made these conclusions? Group A is because it's green, so it's a nice color, calm color, peaceful color, and because of the crescendo pattern, correct? Group B thought B because we are talking about bias. Okay, so whatever is A is not right. Okay. But if I put labels on them, both of them can be progress, correct? So it depends how we look at it, okay? So that's the unconscious mind that wants to push you to a conclusion without even having enough information. So you have to be very careful. You have to sometimes change the way you look at things. The angle most of the time matters, even in real life. Sorry. Your mind wants to see whatever it chooses to see, okay? So it doesn't give you the whole information, okay? Now, I want to show you a clip, and I want group A to caption it for me and to tell me what's your short version story or title on this video. Ready? Anyone? Coffee? The book? Good. Anything else?
Running for your morning coffee.
Very good. Coffee? Good. Okay. Now, group B. I'll show you another part of this video. Now, were they right? No coffee. Okay. So, caption? Anything?
Running from the law.
Very good. Why did we make those decisions? It's because we don't have the whole information, correct? We don't know what's going on. You have to see the whole scenario to make your final correct conclusion. So the first and second part didn't give you enough. But if I change the angle, then you know the whole story, what's been going on. Okay? So completely different, as we didn't expect it. Now, welcome to medicine. You don't think that the medicine is going to be easier than real life. So we don't know what's going on, what's coming through the door, what we are seeing, what we are going to deal with. On top of that, we are pushed by some policies, by some KPIs. Some of them we understand, like medical-based KPIs. So if you know someone's sick, you have to see them quickly. Okay, so that's makes sense. But some of the KPIs that we are dealing with are politically based. And I've never understood why do I only have 4 hours to spend with the patient. So after 4 hours, they are getting expired or getting kicked out of the department. So that kind of KPIs are political and for some reasons that we know. Therefore, we don't have enough time. We have to make quick decisions. You've heard of Gestalt or Gestalt, however you want to pronounce it. And what Gestalt is basically a heuristic cognitive process. So, which is a cognitive shortcut based on our survival instinct. Like, for example, if you see somewhere dark or see snakes, you know that you shouldn't get close to that area. So, the same process comes to sort of activity when you're dealing with some push decision. So that autopiloting helps you to make a quick decision. Now, unfortunately, or fortunately, most medical errors happen because of the cognitive biases that we discussed, and not because of the knowledge gap. And unfortunately, 60 of them's been named, and the rest haven't yet. There are going to be more. Now, you probably know some of them. So the bias usually hits you when you're thinking or making a decision when the patient directly is not involved. We had one of the ED nurses around here. So when you're doing the handover, when you are taking handover, when you are talking to a specialist colleague about a patient that they don't know what's going on, when you are, Tom, where are you? When we are doing a radiology request for a CTC spine and the clinician just wrote leg pain. So these process usually hits you up and you think that you are dealing with the bias. Here is the time that you have to press the brake, step back and think. We constantly work in the mindset of worst case scenario, which is bad. But why? The answer is because we have to. Now, they started M&Ms, increased awareness, education session, presentation like this. But we know none of them is going to help to reduce that clinical errors and bias. However, most of the networks, after creating the guidelines and policies, they try to make a better and safer system to avoid bias, not making better clinicians. Now, going back to the errors, human error, what is it? Do we do them intentionally or we don't do them intentionally? So the definition is very, very, very wishy-washy, as you can see. But as a shortcut, so if you put a retrospectoscope and then you look at what's happened, would you do that or don't do that again? So that's the definition of error. Giving a penicillin to a patient who's got penicillin allergy, is it really an intentional error or is it something that happened because of the bias? Somebody didn't look at the history properly. So these are the questions that crosses your mind when you're dealing with anything in medicine, as I mentioned. Now, let's do a bit of experiment. Hopefully your phones work. I need your phones now. Now, Group A, I'm going to give you a case that similar to one of the experiments or studies that was done in Harvard University. Now, I just want to see how variable your answers are. So hopefully you'll see the case. Nice music. Wasn't this one though, hopefully. Yeah, is it working? Yeah. Okay, so when you're reading that one, hopefully I'll get the case B to Group B. Case B. Nice, they're ready. I have a few minutes to read your cases, and I just want to see how variables are your answer. Now, when you're done, scan this one for your answer. So it starts with A or B, if you are Group A or B, and choose only one diagnosis for the case that you think's been going on. So group A, the diagnosis, group B, the diagnosis. Whenever you're ready, you can put your diagnosis in. Oh, it hasn't started yet? Sorry. I started before coming, probably. There you go. It was the rain, wasn't me. Nice. I'm getting the answers. Don't forget coffee. Very nice. So I have the answers here. Okay. Now, as a backup, because I wasn't sure if the internet is going to work or not, so you have the cases here. Case 1 was this one, as you had it. And case 2 was this one, which you had it again. And the answers that you had were pneumonia, COPD exacerbation, pulmonary embolism, lung cancer, heart failure, and diagnosis not listed. Now, I can see that the case A and B vary a lot, and the group B are more focused on pulmonary embolism. So if you look at these cases side by side, they are exactly the same, but the informations were given in a different area. Okay, so you had the leg injury in the social history part in the case A, but in case B, you had it up front in your presenting complaint, which made you make your choices. But why? Because you had excessive weight on a piece of information that you had the first. So whatever your brain saw and picked first made you be biased based on that decision. Okay? So that's called anchoring bias. The second one was excessive weight on a specific diagnosis. I don't want to miss PE because they might die. But nobody thought, this patient's here because he thinks that he might have lung cancer. Nobody picked lung cancer at all. That was the only concern that he had. He wasn't concerned about cough. He wasn't concerned about breathlessness. He wasn't, do I have a lung cancer? So this part is confirmation bias. And the third one is the premature acceptance of the diagnosis without further investigation, okay? So that's momentum bias or diagnostic momentum. So when something comes here, comes to emergency department, don't think we are more smarter than you. So we do exactly the same thing. We do ECGs, blood tests, before even seeing the patient or talking to the patient. Then after 3 hours, if they are lucky, we go and say, hello, how are you? I'm going to check your result. And then I come back and said, I don't know what's going on with you, let's do more tests. And after those tests, I said, what was the question did you ask? I said, do I have a cancer? Oh, I don't know. Go and see your GP. So that's exactly what happens. Because we don't spend enough time and we don't use our thinking brain. Now, more examples, just some simple scenarios that you've all faced. So 9 o'clock p.m., busy ED. One of your registrar comes to you and said, I've got a 24-year-old female that's got a bit of PV spotting, gravida 1, 8 weeks gestation, no past history, and recently had the ultrasound with the GP, which shows live intrauterine pregnancy. So reassuring. Vital signs, all good. Bloods, okay, BRCG 65,000. The RH is positive, so I don't need to worry about anti-D. But I want to keep them overnight for ultrasound in the morning. I said, okay. We have many studies. We have many policies and procedures that support that you can safely send them home and bring them back tomorrow for the ultrasound. Why don't you do that? Why do you think this decision was made? Because something we call aggregation bias. So we think the patient that we are seeing is different to the other ones that the others seeing. So we think mine is different, special. They might have heterotrophic ectopic pregnancy at the same time. How often does it happen? Plus, you're not going to send them home in the wild. You're going to bring them back and review them. Okay? So the same story happens when you see a minor head injury. So you want to get a CT. The tendency, let's do the CT, let's do the CT. Why? Because this one's different to the others. This one had 20 seconds of LOC instead of 18 seconds. So I'm worried about that. I had 2 vomiting instead of 1 vomiting. So it makes me a bit worried. Or antibiotics in tonsillitis. So we tell people don't give antibiotic, but as soon as we see a tonsillitis, hey, this is the script. Don't fill it, but if you don't feel well by tomorrow, go and get it and start it. Am I wrong? So these are the aggregation bias examples. Now another case, very, very, very dangerous and red flaggy word, frequent presenter. So a 29-year-old female, past history migraine, comes to emergency department every single day on prophylactic propranolol. Now, coming again with headaches, bit of photophobia, and only 1 vomit. History, physical exam, investigation. You just go and say, oh, I have to go and see that one. I know this lady, I'm going to look after her. So you go there and say, oh, headache again? Yeah. Anything else? A bit fluey in the last few days. Okay, maybe I do some pathology, I give you some fluid, give you some aspirin. You already had your propranolol, see what happens. So half an hour, 1 hour later, your nurse calls you and says, oh, the white cell is 18,000. And does have some neutrophilia. Do I need to do anything? Do you want to give some antis? I said, no, don't worry. It's probably because of the vomiting, so you get the shift and white cell goes up. Okay, so frequent presenter, I know this lady well. So you go after a few hours to the cubicle, she's still lying, light's still off, IV fluid running, and the elbow is bent over the eye, and she's sleepy. But you cannot house her. Hot to touch, and now you turn on the light, and so there are widespread rash. And you said, oh, am I missing something? Why did it happen? So this is because of what we call the anchoring bias. So the tendency to focus too heavily on the first available piece of information. Frequent presenter, migraine, it can't be anything else. Scary, huh? Another one. So a 43-year-old female, past history of ovarian cyst, sharp, severe left iliac fossa pain. LMP was 3 weeks ago. Your resident goes and sees this patient and comes and says, I want to give them analgesia, I want to get an ultrasound. I think it's a cyst incident. Can it be something else? No, I don't think it is. It's a cyst incident. Okay? You go there, rolling around, screaming. Does have a bit of left flank tenderness. You do urine ECG, which is negative, so it's a bit reassuring. And you ask for some urine. So 1 plus blood. And you said, can it be kidney stone? And they said, no, it's cyst incident. She's got her period. Might be early. Okay? But you do a CT, and there's a kidney stone. Okay? So that's ascertainment bias. So anything with the ism in the end is part of ascertainment bias. Sexism, gender bias, ageism, racism, whatever you want to call it. So remember the case we discussed, the black skin of color patients getting less analgesia. So that's, we think they are either faking or they have a very high pain threshold. One more. 47-year-old male coming with right side abdominal pain, not very specific, on a Sunday evening, no past history. Blood pressure is a bit up, but nothing really impressive. And you think, I don't know what it is. But you feel a palpable mass, about 4 to 5 centimeters. 47, no. Probably she's too fit, he's too fit or he's too thin. That's why I'm feeling it. You do some blood test, pain goes away, bit of urine in the blood, maybe it's a past stone. Let's go and have a look at the tummy with ultrasound. And they tell you that the machine is broken. I said, yeah, okay, I didn't think it's a AAA anyway, but go home, and probably it's a non-specific pain, either MSK or past stone. So he goes home, hasn't arrived home yet, turns back and comes back to ED. I said, the pain's coming back and it's getting worse. Now you do a CT. Interestingly, it was a 51 millimeter unruptured AAA. That happened to me. Okay, not to me, I was in charge, but one of the patients that we had was exactly the same story. I went home earlier when the night shift was finishing, and then came back at 10 o'clock. We did the CT, and that was the case. So we call this one zebra retreat bias. Because the diagnosis is so rare, you completely dismiss it. So there is no way that this young person can have AAA. What he had. Now, accreditation is coming now and then in Australia in some networks. Now, you know, one of the areas that they're focused on is hand hygiene. And they say, oh, wash your hand, wash your hand, wash your hand. And we don't listen, we don't listen, we don't listen. And they said, there is prize, we give you coffee and some book if you wash your hand. And then we do some of them, and then the accreditation pass, we forget again. So you as a director or as somebody in charge, you want to investigate that one. So you go and have a chat with a couple of people who never wash their hands. I said, why you are not doing that? And they said, it's not a big deal. You're just too worried about them, okay? And then they start laughing at you. So that's Semmelweis reflex, okay? Now, the name's coming based on Ignaz Semmelweis and Oliver Holmes. Now, it's nice to know about the story behind these medical adventures as well, as you might. So both of them were obstetricians. You might know Oliver Holmes based on some poems that he wrote, but he was a clinician as well. So they realized that in obstetric ward, if a midwife does the delivery, the mortality is different to if the clinician does the delivery. So 10% for clinician, 4% for midwives. I said, why this is happening? So it goes back and said, the only thing that's different is the midwives washing their hand before they do the delivery. That was at the same time that Louis Pasteur just said that, you know, hand hygiene is important. So they went back and told all the obstetricians that you have to wash your hand. It reduces the postpartum infection and sepsis. And they started laughing at them. So that's what they call it, Semmelweis reflex. So when you say something that doesn't make sense to most, they start laughing at you. So it's a good sign if they laugh at you. You might win Nobel Prize later. Now, some biases are a bit more complex than what we discussed already. One of them is just yin-yang out error bias, which is a combination of diagnostic momentum error and base rate neglect. Now, base rate neglect is a bit complex, so it's just basically consideration of the probability when you're dealing with a diagnosis or differential. Now, in terms of the diagnostic momentum, now we have some paramedics as well, Quent and Dylan backgrounds. Now, you get a call, bad call. I'm bringing you a 62-year-old male with LAD territory STEMI on ECG. Okay, are you ready? Yeah, sure. We get the cardiologist cath lab standby. Let's see what we have. They arrive. Your systolic blood pressure is 220 over 140 with the heart rate of 125. Now, the question is it still a STEMI? Or it's something nastier like dissection? Okay, so some people, they said, oh, I saw that. Can I unsee it and send them to cath lab? It happens. Yeah, people go to cath lab with dissection type A and then they die on the table because we turn our back. I said, I didn't see that one. Okay, but now that you saw that one, I'm sorry, you cannot unsee it. Now, in the end, I have to show you this picture. So I like to put this one at the end of most of my talks because you can choose to how do you see this one. It's a proud lobster hugging the planet Earth, looking at the galaxies and the stars, or a lobster miserably sitting at the bottom of a bucket ready to be cooked. So the way that you look at it matters. Now, can we save ourselves? Yes, there is a procedure called debiasing strategy. So we like to call them diagnostic timeout. We have timeout for everything. They're going to theater, timeout. They're going to the war, timeout. Handing over, timeout. Why not for this one? Okay. Now the question that you have to ask after you've done everything and you're happy is that, is there anything else that I can be missing? I've got a patient, 40-year-old with appendicitis. Is there anything else? Or am I sending this patient to theater for diagnostic lab for a kidney stone? And the second part is there something that I don't like about this presentation? Yes, this patient's pain is at the front going to the back and can't feel their leg. Can be appendicitis. I don't like that. So this question that you're asking helps you to activate the type 2 thinking and unbias yourself. And sometimes asking for a second opinion is very helpful. So fortunately, the department that I'm working at, we have a very sort of friendly environment, so you can easily go to anybody you like. I said, I've got this patient that does have a very sore wrist, but I don't see any fracture. Do you see anything else that I'm missing? Or I call my radiology registrar and I said, this guy's leg is swollen like an elephant, but there is no fracture. Is there anything I'm missing? They look at it and then they give you a second opinion. So the metacognition, basically, that's the process. Now, some takeaway points. A significant number of diagnostic errors, as we discussed, are because of cognitive bias, not because of the knowledge gap, not because we don't know. We know them, but we get tricked into the wrong one. We have many forms of cognitive bias. Some of them are diagnostic, some of them are therapeutic. So this is the new category that just came out last few months. Now, clinicians are inconsistent in recognition and characterization of the bias, not with the knowledge, not with the patient flow, not with their management. So if somebody's in pain, everybody's going to give them pain relief. But what to give it and how much to give it to whom is the question. Now, debiasing, as we discussed, might help you, not in practice, but even in real life. Now, this type of the diagnostic and the therapeutic bias that I mentioned, so these are the table. Now, because everybody was interactive, everybody gets coffee. No, but you can download the book, and if you want a better version of that one, if you find me somewhere, anywhere in Australia, here, outside, inside, I'm happy to give one copy to you as well. I'll bring this back if you want to download it. I'll leave it up actually, so you can